Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and independently sponsored by Amgen.
This program is presented by Medscape Education Global.
Hello, I'm Jimmy Udin. I'm an oculoplastic surgeon, ophthalmologist, and I've been running the thyroid eye disease service for nearly a quarter of a century at Moorfields Eye Hospital in London. Welcome to this program titled Thyroid Eye Disease, All You Need to Know. I'm very lucky to have my colleagues who will be involved in this program. Our first speaker is Dr. Marco Celes-Sanz, who's Chief of Oculoplastics Unit at University of Alcalá, and he'll talk about thyroid eye disease facts and pathophysiology. Then Dr. Diego Strionesi, who's Chief of Oculoplastics at University of Naples, he'll tell us about thyroid eye disease diagnosis and how to look at the difference in different types of thyroid eye disease. And then Dr. Tomasz Bernazuk, who's Professor of Endocrinology at Medical University of Warsaw, and I will discuss how we manage thyroid eye disease, both from an endocrinology and an ophthalmology perspective. And then finally, I'll wrap up with concluding remarks about this section. Thank you. So I'd like to welcome Marco to talk to us about thyroid eye disease facts and pathophysiology.
Hello, I'm Marco Celes-Sanz, head of unit in the Orbital Oculoplastic department in Ramón y Cajal University Hospital in Madrid. And I welcome you all to this section titled Thyroid Eye Disease, Disease Facts and Pathophysiology. First, we will set the scene and review the key points about the epidemiology of the disease, remembering that Graves' disease remains the commonest cause of hyperthyroidism, with a prevalence of 2% with an annual incidence of 20 cases per every 100,000 persons. The prevalence of thyroid eye disease varies depending on the population studied, but we can say that it affects around 25 to 50% of patients with Graves' disease, with a prevalence of 0.1 to 0.3%. So it is a rare disease, but not uncommon, and it must be considered in any patients with the key symptoms that came to the ophthalmologist, but also in any patients with Graves' disease that came to the endocrinologist that presents any ophthalmological symptoms. So we need to know that it is the most frequent cause of orbital inflammation, but also orbital inflammation can be secondary to many other diseases. So making a proper differential diagnosis is essential in these patients. About the pathophysiology of thyroid eye disease, we need to know that it's a cellular and humoral immune dysfunction. One of the key points that these patients present is that the orbital fibroblast in this patient present an overexpression of the TSH receptor and the IGF-1 receptor. TSH receptor are activated by the excess hormone or by thyroid-stimulating antibody that these patients present. This results in the differentiation of orbital preadipocytes, a subgroup of orbital fibroblasts, into adipocytes with consequential increase in orbital adipose tissue. IGF-1 and its receptors are also overexpressing T and B cells in these patients, and the stimulating of IGF-1 receptor results in the activation of inactivation of orbital fibroblasts, proliferation, cytokine secretion, and hyaluronan synthesis, perpetuating the inflammation and the tissue expansion that these patients present. It's very important also that these two receptors, IGF-1 receptor and TSH receptor, are co-localized on orbital fibroblasts and are thought to have a synergistic relationship with cross communications between them. That means that activation of the TSH receptor by thyroid stimulating antibodies may also activate the IGF-1 receptor intracellular cascade. Also, these patients present activated T cells and orbital fibroblasts that secrete IL-6, which encourages B cell maturation and subsequent secretion of more thyroid-stimulating antibodies by plasma cells. This results in further cellular recruitment, cytokine secretion, and tissue expansion, promoting the cycle of the disease. And finally, orbital fibroblasts in thyroid disease patients may also activate the adaptive immune response through their expression of CD40, a co-stimulatory protein. The CD40 ligand found on CD4 positive T cells create a bridge between the CD40 and the CD40 ligand, which activates orbital fibroblasts, which releases more cytokines, mediators, and promotes fibrosis. That this is especially important in the late phase of the disease. So in the past, the disease was treated mainly by dialing down the inflammation in general within specific drugs, mainly steroids, with varying efficacy. But now we are on the era of targeted therapy, being the new drugs focus on the treatment of the IGF-1 receptor, the FcRn, and the IL-6 and other cytokines that are active in this disease. So we are trying now to block specific pathways that leads to the signs and symptoms and the mechanisms that promotes this disease. So now we have teprotumumab that blocks the IGF-1 receptor pathway, and we have tocilizumab that block the IL-6 pathway. But we have new drugs such as BRTN-001 and others BRTN drugs. We have loniguantamab and lincitinib that blocks IGF-1 receptor also. We have satralizumab that blocks IL-6. We have batoclimab that blocks FcRn and block the Ig recycle, and other drugs such as statins, belimumab, or secukinumab are being treated, trying to block different pathways of this disease. About the burden of the thyroid eye disease, we need to know that the disease not only affects functionality, but it also has a significant impact on the psychosocial sphere of these patients, greatly impairing the quality of life. Changing appearance is the most frequent symptoms that these patients present, and it implies a big loss of quality of life. Also, we think that it affects mainly young women. Inflammation causes eyelid discomfort, even in mild cases, making the patients aware that they have eyes the most part of their daily lives. But also, we have to know that the most severe cases can be vision threatening, mainly because optic nerve compression and dysfunction, being the risk of vision loss around 5%, between 2 and 8%, depending on the series. So it's very important that in these patients, we rule out always an optic nerve dysfunction to find the patients with a high risk of vision loss. Also, smoking is a fundamental pathogenic mechanism, and quitting smoking is essential in the treatment. We need to know that the stress is a bad factor for the disease, and the fact that the patients need to quit smoking often adds more stress to this patient and makes treatment even more difficult because they need to quit smoking, but that adds also more stress to them. Now, please, we will continue on the next section on thyroid eye disease diagnosis with Professor Diego Estrianes. Thank you very much.
Hello, welcome to the section on thyroid eye disease diagnosis. I'm Diego Estrianes, Chief of the Oculoplastic Unit of the University of Naples. And today I will dive on the assessment on thyroid eye disease. Traditionally, we use the clinical activity score, or some people in some center in the United States, they like to use VISA classification to assess the activity, which means the inflammation of the thyroid eye disease. So when we end up with a score that is equal or above 4, normally the patient should be treated with immunosuppression therapy. At the same time, we should also carefully assess the severity. If the patient has sign of compressive copy, neuropathy, or findings of corneal breakdown and severe corneal breakdown, the patient should be treated urgently. So those are the signs and symptoms that you can find easily on all the papers and book about the assessment for clinical activity score. And this is the quality of life test, which is also very important nowadays when we assess the patient and we have to take the decision to start eventually any treatment. But today, I'd like to share with you a case that, to me, is very teaching case because it's escaped a little bit to what we have so far in terms of assessment of patients. This lady, 45 years old, has a clinical history of several attempts to conceive, unfortunately, with no successful result. And she starts to have in between May and August 2023, some problems, some eye problems, particularly tearing and intermittent discomfort. She had seen by several ophthalmologists, and she got some diagnoses like conjunctivitis, allergic conjunctivitis, viral conjunctivitis, and eventually dry eye. So she ended up using eye drops, lubricants, but with no result. Finally, in September 2023, she had been diagnosed with hyperthyroidism, and she had been commenced with methimazole 5 milligrams twice a day. And that was in September. Look what happened in February 2024. She started to have redness of the conjunctiva, redness of the eyelid, and chemosis. And she was assessed as having a clinical activity score of 3. Visual acuity was good, and there was no impairment of color vision, and fundoscopy was also fine. That's why she was just given some oral steroids. And look to the serology and see that she had an increase of the value of antibody against the TSH receptor over the time. Particularly, this is the last value. Look in February 2024. And that's what happened in the same month. Although she was under steroids, she developed she worsened in terms of appearance, and she also had some sign of compressive optic neuropathy, particularly in her right eye. That's why she was started with high V-pulse steroid therapy, particularly methylprednisolone 500 milligrams IV, as suggested to all the guidelines, European guidelines at least. And you see that although she was under treatment for with the pulse steroid therapy, the value of the antibody against TSH receptor was still quite high and increasing. And you see that after 4 doses of IV methylprednisolone, she was not improving at all, and visual acuity was not improving, and even the clinical appearance, as you can see in this picture, was worse. That's why we decided to give her tocilizumab, because we were concerned that she was not improving. Maybe we thought that she was steroid resistant. And you see what happened after tocilizumab? Again, got worse. And this is the real life. This is the real life picture after 2 days of tocilizumab. It looks like a very severe case, desperate case. You can see from the CT scan, she has an extraocular mass enlargement, fat adipose tissue, retroorbital fat adipose tissue increased in volume, and stretching of the optic nerve that eventually might also contribute to the threatening of the vision. So we decided to do orbital decompression plus tarsography, and she get better. We still kept her under some immunosuppression, which was cyclosporin and prednisolone. And she went well, quite well for about 4 months. But look what happened after 4 months. She developed again recurrence and a flare of the disease in left eye with some kind of decrease of the vision. So this case, I think it's a little bit different from what the Randall curve normally says to us. Because we think that if we start the treatment in the early stage, maybe we can change the course of disease and we can prevent the severe and significant complication of the disease itself. But as we have published a series where we found that some cases, about 20% of thyroid eye cases, they have some different course of the disease. As you see here, this gentleman had decompression in one eye plus steroid therapy. He went quite well. And then afterwards, he developed, after 2 years, recurrence of the disease in the left eye. So still, we should trust about Randall curve. I would say no. Thyroid disease can be very difficult disease because of the variation among case to case. So when I think it's important to assess the patient using clinical activity score. Clinical score is a good value, but we cannot trust only on clinical activity score. Clinical activity score is just the snapshot of the day that we have the patient in our office in front of us. But we cannot have the therapy decision on making a process only based on a clinical activity score. We can also use the visa which was also validated by the ITEDS group. We can use the severity grading in mild, moderate to severe. But most important things that we should consider is the serology as well, and particularly the antibody against the TSH receptor, which are high, which carry a high sensitivity, which means that if the patient has an increase of the value over the time, the patient most likely will get worse in the future. And the third most important things that we should consider, beside the clinical activity score, beside the antibody against the TSH receptor, is the progression of disease. As I've shown with my cases, the patient complain that in 1 month she get worse in terms of redness and inflammation. And I think that this is the important point that I'd like to emphasize today. Progression of disease. If in your office you have a patient with a clinical activity score around 2 or 3, with eventually with blood tests with TRAB very quite high, and patient complain that he get worse in the last couple of months, you have to be aware. If you can handle the patient, then give to him or her an appointment in 2-3 months, or even, I would say, if you are worried, but in 2-3 weeks. But if you cannot handle the patient, just refer immediately to an expert ophthalmologist that can assess properly and commence eventually, if needed, a proper immunosuppression therapy. So once again, I would say clinical activity score, blood tests in terms of monoclonal antibody against TSH receptor, and most importantly, progression of disease. I hope that this case presentation today will help you in the future assessment of a thyroid patient. Thank you so much for your attention, and please stay tuned and continue to follow the third section on thyroid eye disease about management from both ophthalmology and endocrinology perspective with Jim Udin and Thomas Bednashuk.
Hello, it's me again, Jimmy Udin, ophthalmologist from Moorfields Eye Hospital, London. Joining me in this section is Thomas Bednashuk, endocrinologist with vast experience in hypothyroidism and thyroid eye disease from Medical University of Warsaw in Poland. And welcome to this section titled Thyroid Eye Disease Management. And Thomas will start this off.
Thank you very much. I think we should start by saying that there is a need for a close collaboration between endocrinologists and ophthalmologists when we are talking about the management of patients with thyroid eye disease. The endocrinologist should be familiar with the basic elements of the TED examination, and they should also identify the referral pathways both to ophthalmologists and specialized centers. There are several steps that can be taken to reduce the morbidity associated with thyroid eye disease. First of all, the diagnosis of GD, Graves' disease, has to be properly made. And here we usually should measure antibodies against the TSH receptor. If we are managing patients with Graves' hypothyroidism, we should screen the patients for eye disease at each visit. We should also alert the patients with Graves' disease of the risk of TED, of the symptoms, and where they should go if such symptoms occur. The most important part would be probably to prevent TED development and progression, and very important to refer to specialized clinics early. How can we prevent TED development and progression? First of all, physicians should urge all patients with Graves' disease to refrain from smoking. Then, euthyroidism should be promptly restored and maintained in all patients, avoiding episodes of hyperthyroidism and hypothyroidism. Treating patients, we should remember that antithyroid drugs and thyroidectomy have no impact. They do not modify the natural history of TED, whereas radioactive iodine can carry a small risk of TED progression. This can be inhibited by concomitant use of glucocorticosteroids. In some patients, we would also use selenium supplementation, and recent data also suggests that treating lipid disorders might be helpful for them. If we are talking about patients with TED, we need to remember that it is a very heterogeneous disorder. In many cases, especially in older patients, it can involve the eye muscle enlargement causing periorbital soft tissue congestion, or in severe cases, optic nerve compression. But this disease can also affect predominantly or just purely the orbital fat, or only the eye muscles, or only the eyelids. Therefore, a personalized approach to TED management is necessary, and the treatment plan has to be based not only on the disease activity severity and the duration, but also how does this disease impact the daily living of the patient? What are our goals? What is patient's age, comorbidities, patient preferences, and also important, the availability of different drugs and costs. In patients with mild disease, we would usually prefer the watchful monitoring strategy. In some cases, especially in patients living in selenium deficient areas, a course of selenium supplementation might be useful. But again, it is very important that in an inactive phase, even in patients with mild disease, sometimes rehabilitative surgery needs to be considered. But now I think we will move to a much more complicated scenario, the management of patients with moderate to severe disease.
Thank you, Thomas. So as Dr. Strianese has already outlined, thyroid eye disease can be classified into mild, moderate, and severe. So we're going to be discussing the moderate to severe disease. So how do you manage these patients? UGO, European Group on Graves' orbitopathy, have done a lot of studies looking at the management of thyroid eye disease. And this is their guidelines in 2021. And what they suggest with moderate to severe thyroid eye disease that is active is to use intravenous steroids. So for the more moderate, use 500 milligrams intravenous methylprednisolone on a weekly basis for 6 weeks. If it's a little bit more severe, then you can use 750 milligrams intravenous methylprednisolone weekly for 6 weeks. With the more moderate disease, you can also introduce mycophenolate early. If they respond to your intravenous steroids, then you continue with treatment with a further 6 doses of intravenous steroids with the first group of the moderate disease at 250 milligrams weekly for 6 weeks, along with mycophenolate for 6 months. And in the second group, with the more severe disease, you may carry on with half a gram, 500 milligrams weekly for a further 6 weeks. Hopefully your patients will respond to treatment and not progress and maybe get better, and then they will revert to the inactive stage of thyroid eye disease or Graves' ophthalmopathy, which isn't at the end of the 3-month treatment, but sometimes a bit longer. If they don't respond well enough, and that is a subjective assessment, then you can consider second-line immunosuppression. So what is second-line immunosuppression? So you can give them more oral steroids, or you can give what I would say is slightly weaker oral immunosuppressants, such as cyclosporin and azathioprine, which have been widely used for many years in more rheumatological setting. You can consider other modalities of treatment. Radiotherapy is still widely used, and there's good evidence that radiotherapy helps with active thyroid eye disease. And then you can also consider biological treatments, and drugs such as B-cell depleters, rituximab, and tosilimab, anti-IL-6, have been used for many years with some degree of success. And then there's been the introduction of teprotumumab in the US since 2020, which can also be used if you have access. Then you hope, if they needed second-line immunosuppression, that they settle down and then revert to inactive thyroid eye disease, and I'll discuss that treatment management there. But if they don't do well enough, or if they progress, and particularly to optic neuropathy, what do? It gets more difficult, but there's another option that you can treat patients with who've failed with immunosuppression, and that's to consider decompression. And again, understanding different types of thyroid eye disease and the particular phenotype may be important. So the European Thyroid Association and the American Thyroid Association had a consensus statement in 2022, which essentially was very similar to UGOGO. They advocate intravenous steroids, particularly for inactivation of clinical activity scores and active disease to improve eye movements. And they also suggest that you can add radiotherapy as well. But notably, they suggest teprotumumab as first line for disease inactivation and reduction in proptosis, and also motility improvement. And if these two therapies don't work or are not the only therapies available, then you can revert to similar drugs as UGOGO has suggested, such as rituximab and tosilimab. So just to look at some of the difference between different parts of the world, and I've just highlighted Europe and USA. So intravenous steroids, and you can see that that's still the mainstay of treatment in Europe. And in the US, nearly 40% of patients use teprotumumab for their treatment of thyroid eye disease. And that is largely due to availability of the drug, which is not available in many parts of the world. So moving on to sight-threatening thyroid eye disease. So when things are really bad, and perhaps you have optic neuropathy as well. So the treatment is still intravenous steroids, but you may use higher doses and more frequent, up to 1 gram sequentially. If things respond reasonably well, you may consider adding radiotherapy, although that may be controversial, but you would also consider adding other second-line immunosuppression as well. If patients don't do well, then you tend to go towards orbital decompression. But you still have the ability in your own practice to use other drugs, such as rituximab, tosilimab, and teprotumumab. But what's important is to try and identify the type of thyroid eye disease, or the TED phenotype. And we described a number of phenotypes, but for example, with optic neuropathy and severe disease, there are two particular phenotypes. One is a hydraulic, where you have a lot of congestion, dilated vessels, and the other is what we call a white eye apex. And both can be categorized using radiology, and they are better served with decompression if immunosuppression does not work. So when the patients settle down and they become into the inactive phase of the disease, they usually undergo surgical rehabilitative surgery if necessary. So that's how you treat thyroid eye disease in a nutshell. But how, Thomas, do we think about which treatment options should be used, particularly with moderate to severe disease?
One thing that we could consider, it is the efficacy of different drugs in looking into particular symptoms. And if we look at the drugs available, that glucocorticosteroids, other non-specific immunosuppressants, rituximab and tocilizumab, all of those drugs are highly effective in inactivating the disease. However, they might differ a little bit in their response to proptosis, to eye muscle motility, and to the reduction of the lid aperture. Here, the effect is usually small or modest, but there may be some differences here. The drug that made a difference was teprotumumab, because this was the first drug that showed a really good response looking at the proptosis and the eye muscle dysfunction with diplopia. So one thing to consider would be which drug would be best for treating specific symptoms in each individual patient.
Are there times when, because it's suggested that you either use intravenous steroids or teprotumumab as first line and other drugs as second line, but are there times where you might consider having a different option?
Then the second step that you can consider, it is also the comorbidities of the patient. Glucocorticosteroids have been used for decades, and we know the safety profile of this drug. And it should be used in caution, especially in patients with liver disease and in patients with cardiovascular diseases. In such patients, other immunosuppressants such as rituximab and tocilizumab may be considered as first-line treatment.
Thank you. Okay, so we'll now move on to emerging therapies in thyroid eye disease and ongoing trials. Do you want to just tell us the background to why new therapies may be useful?
Yes, there are really exciting new therapies in the horizon for the patients, and it all came from a better understanding about the pathophysiology of thyroid eye disease. Definitely the most important one in the pathophysiology is the interaction between orbital fibroblasts and the infiltrating leukocytes. And the interaction can be both cell to cell, or by autoantibodies, or by cytokines. In the active phase, the orbital fibroblasts can produce glycosaminoglycans, or they can undergo adipogenesis. In the inactive phase, there's usually predominantly fibrosis. And based on those factors, we have now certain agents that could interfere in some of the points, specifically addressing the pathogenesis of the disease.
Thank you. Yeah, so we know that B cells and antibody production is important, and we're familiar with rituximab as a B cell depleter. We're also familiar with certain anti-cytokines, such as anti-IL-6 pathway with tocilizumab. And there's been a lot more work and interest in the relationship between the TSH receptor and the IGF-1 receptor signaling with the TSH receptor antibody, and that's with the advent of teprotumumab, but there are other drugs also being trialed with similar action. And there's also this idea of actually just reducing the antibodies completely. So you have drugs that will reduce all antibodies, and that may be through the neonatal FcN receptor recycling pathway, but essentially all antibodies are reduced, including the TSH receptor antibody. And these types of drugs are also used in other autoimmune disorders such as myasthenia gravis. Other cytokines are being looked at in terms of pathways, and such as anti-IL-11. And also, we're also looking at intracellular small molecules that will disturb certain pathways, including the IGF-1 receptor pathway as well. So a lot of exciting drugs being tested and may be available. So it's really important that patients are referred to centers of excellence who may have access to trials as well as conventional therapy. So just to conclude, thyroid eye disease is a rare, heterogeneous, vision-threatening and disfiguring autoimmune process. And it's really important that it affects the quality of life of patients, and you must take the patient into account. Thomas has already said how important it is to have a personalized approach and a multidisciplinary decision-making team with a minimum of ophthalmologists and endocrinologists, but you also will include radiologists as well. And it's this close communication and putting the patient at the center to decide what's the best treatment. Non-specific immunosuppressants such as steroids are still being used, and they've been the most used and first-line treatment in thyroid eye disease.
And several other immunomodulatory monoclonal antibodies have been also used, like rituximab and tocilizumab, and they have shown a place for efficacy for inactivating thyroid eye disease. Recently, teprotumumab and insulin-like growth factor receptor 1 inhibitor has demonstrated significant improvement in proptosis, clinical activity score, and diplopia. Surgery is reserved for rehabilitation in chronic TED and for emergent compressive optic neuropathy. New, like you just mentioned, new promising therapies in ongoing clinical trials may offer improved outcomes in TED patients.
It's really important to recognize thyroid eye disease and to suspect it, and then to refer to centers of excellence or specialism who can then offer treatment options and potentially emerging therapies as well. Thank you to Thomas and the team. I will now provide some concluding remarks about the program and all you need to know about thyroid eye disease. Thank you for listening and watching about thyroid eye disease, all you need to know. And you've heard about the latest and very interesting developments on pathophysiology of thyroid eye disease with Marco Salas-Sanz and how that leads into new therapeutics. And then Dr. Diego Strionesi talked to us about the importance of looking at disease severity and activity and how that leads on to choosing the management type. And then Dr. Thomas Bernazuk and myself discussed the treatment options of active and inactive disease, as well as the emerging treatments and potential treatments that may happen in the future, as well as trials. Thomas, Diego, and Marco, thank you for your participation and for the great discussion and insights into thyroid eye disease. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.